Thank you for the introduction. So what I'm going to talk about is coming from the background, the situation in the Netherlands where we do not have a lung cancer screening program yet. The Dutch Health Council did have a positive recommendation relating to the positive effect of lung cancer screening of lung cancer mortality, but they have identified a number of issues that need to be resolved, and the protocol that we will propose in a working group in the Netherlands will be evaluated again by the Health Council, and they're very much focused on the impact of screening on healthcare resources, in particular due to the workforce issues that we're already facing with radiologists and radiographers, but also the impact on GPs and doctors in the hospital. And so that's basically the background of this talk. These are my disclosures. To think about what could we potentially do to improve the protocol efficiency from a radiology point of view. And these questions, I will shortly address them, and they're mainly focused on steering up discussion, because I think we still lack a lot of the final knowledge to be able to implement this. So first of all, could we go for a biannual screening instead of an annual screening? Logically, this would reduce the number of scans by a lot. We have results here from the Nelson trial. In Nelson, we used a 1 year, then a 2 year, then a 2.5 year interval. And we found that actually the stage 1 percentage and stage 4 percentage were similar for 1 and 2 year follow-up. But at 2.5 year follow-up, there was a clear increase in stage 4 cancers. So it seems that up to 2 years interval could be done in a screening setting. There have been a couple of trials and studies that have been looking into specifically, could we indeed in a certain group in the lung cancer screening population prolong the next screening to 2 years? The MILE trial actually did a randomization where they either did an annual screening or in those with no nodules or very small nodules, a biannual screening. And they found a similar sensitivity specificity for lung cancer, but a third less CT scans. We modeled similar thing in Nelson, and we found that in those with no nodules or small nodules in baseline, up to 100 cubic millimeters, there is a similar low risk of lung cancer up to 2 years. So this also is supportive evidence. And in the long run trial that's currently ongoing, there is a specific focus also on evaluating biannual screening in a subgroup. And actually, there is already a screening program that uses this in British Columbia. You see here in red, when there is when there are no nodules or very low risk nodules, there is a recommendation to do 2-year follow-up screening. Now, another trend, and this is very recent data based on microsimulation studies from 2 different groups, is whether we can already just use age and smoking history to determine whether a biannual screening could be okay. And they found actually that fixed annual screening is the most effective because you find all the cancers, but is the least efficient. The best performing strategy is to do a biannual screening between 50 and 60 or 65, depending on 2 models, and then start with your annual screening, because at that point in time, your risk for lung cancer increases. This preserves finding nearly all the deaths that you can prevent, and it reduces CT screening scans by 21 to 60%. So I think we need to be looking into this more also when you start a lung cancer screening program in a resource-constrained situation. Next question is, do we really need a radiologist as a first reader? Some studies, mainly from the UK, before they started their screening program, looked into the possibility of using a radiographer as a first reader. First of all, they found that if the radiographer starts with looking at nodules and then gives the result to the radiologist, it saves time for the radiologist and it increases the sensitivity, but also the false positive rate. When Computer-aided detection was added to the radiographer evaluation. So the radiographer had access to the CAD. Then the sensitivity specificity was actually even higher than a screened radiologist without access to computer-aided detection. But in their latest results, they also included the evaluation of incidental findings, and then there was no possibility to leave that only up to the radiographer. So the final conclusion, also in the UK, was that radiographers unfortunately cannot be the first readers. And of course, we have a shortage, as we just heard, of radiographers. So it just moves the problem to another field. Newer thinking is, can we use AI as a first reader? So we know that about 50% of screenees have no nodules. Could we just use AI with a very high sensitivity to already take out all those scans without nodules, or even those with small nodules that don't need a short-term follow-up? And this has so far been investigated by one group with one software. They found a very high negative predictive value. And this reduced the workload for the radiologists by up to 87% for nodules. However, in the European Union, because of the European Union AI Act, we're not allowed to use AI as an autonomous software. So we need radiologist supervision, which will still need to check the result of the AI. So within the current boundaries, this will not be the solution, but maybe, hopefully, for the future. There is a very recent health technology assessment from the UK NIHR Institute that actually says that we have very limited information and evidence on AI for lung nodule detection and quantification, specifically when we're looking at clinical outcomes. And so we need to get more evidence to make the recommendation for AI stronger. Last topic, should we actively search for incidental findings on a low-dose CT? Remember, I'm here to stir up some discussion. But when you look at this statement, this is from the European Multi-Society Statement on Incidental Findings. It literally says, LDCT is designed to detect lung cancer, is suboptimal for diagnosis and evaluation of extrapulmonary abnormalities, in particular many soft tissue abnormalities. Think of all those small things in the thyroid or in the kidneys, or in the subcutaneous fat, etc., etc. You see here the overview of all the different things that you could possibly find in all the organs between the thyroid and the kidneys. But if we have to start looking for all these things, it's going to take a long time to go through a low-dose CT. And depending on what you use as cutoff and as a list for incidental findings, the prevalence in screening trials have been found between 8 and 34%. In Nelson, we had a very small list, mostly larger findings in kidneys, liver, etc. But of all the findings that we gave to the GP, only one was actually malignant in the end. So the conclusion was that it didn't make sense to search for all these potential findings. And if you do have a standardized list, as it just showed you, there is still high variability between radiologists in what is reported, if it's given the long RADS S classification, and what kind of advice is given. And actually, very recent analyses, both in the US and the UK, show that on the one hand, a lot of screening costs are associated with these kind of incidental findings, while only a minority will actually have a change in management. So we've been, in the working group in the Netherlands, we have been discussing in depth how we should be dealing with this in a potential future screening program. And we consider that for many incidental findings, we have limited or no evidence on health benefit. So we do not think that active search for incidental findings and workup is sensible. And we have an added advantage in a centralized systematic screening program, namely that in principle, individuals will come back in 1 or 2 years for their follow-up screening. So if there's something very small and dubious, in 2 years you can see if it has become something that is relevant. So our proposal will be to limit the reporting workup to urgent findings and to selected clinically relevant incidental findings, and basically something that the eye of the radiologist will catch when it just scrolls one time through the CT scan. This is our short list so far, up for discussion. And I would like to make one last statement. I'm not talking about comorbidities among individuals with a long history of smoking. Emphysema, corneal calcium, likely also osteoporosis are to be considered comorbidities. And we know, especially for emphysema and corneal calcium, that there's a strongly relation between finding these actual comorbidities and lung cancer risk and cardiovascular disease risk. So these should, in my opinion, have consequences. Thank you for your attention.